Good morning, everyone. So my topic for today is obesity post kidney transplantation. I have no relevant disclosures. So I'll be dividing my talk into these categories. We'll briefly talk about the definition and obesity pre-transplant, and then concentrate on outcomes of obesity post-transplant, the risk factors of obesity post-transplant, and its management. So very briefly, everyone knows about this, but we categorize obesity based on the BMI. And we know that normal BMI is 18.5 to 25, and more than 25 to 30 is overweight, and more than 30 is considered obesity. And then that can be characterized further into class 1, class 2, class 3. But BMI criteria is limited because it does not account for sex, race, proportion of total muscle mass, or body fat. And in patients with kidney disease, it can be confounded by fluid retention. So the other criteria that we might use to characterize someone with obesity is waist circumference. And it's particularly recommended for someone with a BMI between 25 to 35, because it's likely that someone who has a BMI more than 35 will also have a higher waist circumference. And it's important because waist circumference is a marker of abdominal adiposity, and it can correlate with cardiovascular outcomes. In the US, the waist circumference more than 102 centimeters in men and 88 centimeters in women is considered significant for intervention and considered abnormal. But people with Asian ethnicity, even a waist circumference of more than 90 in men and greater than 80 in women can correlate with adverse outcomes. When we talk about pre-transplant obesity, and there's an obesity paradox, we know that obesity prevalence is increasing in CKD and ESRD patients, but it impacts mortality differently in different stages of CKD. So we have, this is a heat map of mortality at different stages of BMI. And we can see that in stages of CKD, higher BMI is associated with higher mortality, but it's inverse in patients with pre-dialysis or patients on hemodialysis, where higher BMI is actually associated with lower mortality. But again, it's reinverted in after kidney transplant, where it's similar to how it is in CKD population. So although BMI or obesity being beneficial in ESRD can affect the transplant candidacy, because a lot of centers have a BMI threshold to consider patients for kidney transplant surgery. For American Society of Transplant and for European Renal Association, they have a target BMI less than 30, but specifically with diet and exercise and under supervision. Although KDIGO does not have any BMI target, because they understand that patients on ESRD do not need to aim for a very low BMI, but they do recommend offering weight loss interventions prior to transplant. Coming to post-transplant obesity, so we know that weight gain occurs in both patients who are obese and non-obese at the time of transplant. And the average weight gain is about 5 to 10% in the first year. But it's important to note that the increase is more in body fat rather than the change in the lean body mass. And that's what leads to what's called the sarcopenic obesity. In a study from Poland, at 24-month follow-up, although the number and the percentage of obese, overweight, normal weight and sarcopenic patients didn't change. The percentage was similar. But if you look at the composition of of fat and lean body mass, so this is percentage of fat and this is fat tissue index, both were elevated significantly at 24 months as compared to baseline at the time of transplant. And the lean body mass was lower at 24 months as compared to baseline. This was a study then done at our center, looking at the truncal fat, the truncal mass, and the whole body fat and the whole body mass. and again found a similar pattern at 1 year. So this was 12 months compared to baseline. There a significantly high truncal fat and truncal mass, but no change in the trunk lean mass, and same with the whole body parameters. So it leads to this model of sarcopenic obesity, where the patients after transplant are gaining weight, and sometimes gaining weight to a point of gaining BMI enough that they go from one category of overweight to obesity or class 1 to class 2 obesity. But they're doing it by gaining more fat and losing more muscle, which is not, rather than gaining weight in a healthy manner. Talking about obesity and post-transplant outcomes, so we know weight gain is a strong independent risk factor for patient and graft survival, and I'll talk more about it later. But just thinking about how increased weight can affect post-transplant outcomes, in the early phase, there are more surgical complications, lymphoceles, hernia, leads to prolonged hospital stay and readmissions. It's also associated with delayed graft function and acute rejection in the first 3 months. In the late post-transplant period, it's an independent predictor of albuminuria. It's negatively correlated with GFR. And as previously mentioned, it's associated with post-transplant diabetes and cardiovascular morbidity and mortality. This was a SRTR study from 2016. So they looked at 10 years kidney transplant recipients and divided it into different BMI categories. And as the BMI increases, and this was true with deceased donor as well as living donor recipients, as the BMI increases, the graft survival was worse. And this was true irrespective of this, the status of diabetes. It was true, the correlation was similar with presence or absence of diabetes. So weight gain in itself was a risk factor. This was a study done by Dr. Kavesti at our center, looking at close to 1,000 kidney transplant recipients. And they found a higher waist circumference when adjusted for BMI. So in this study, the BMI adjusted for waist circumference was not a risk factor, but it was the other way around, where waist circumference adjusted for BMI was a strong predictor of mortality after getting transplant. And this graph shows the non-adjusted, and this shows the adjusted. And you can see both the graphs separating. And here the median waist circumference was 103 centimeters. Obesity is also associated with inflammation. This was another study that done at our center, where they divided patients who gained weight versus lost weight at 12 months after transplant, and looked at specifically at T bars, which is a marker of a measure of lipid peroxidation and a marker of oxidative stress. And at baseline, there was a difference between patients who would eventually gain weight, but at 12 months, although the patients who did not gain weight, the T bars was similar. In the patients who gained weight, the T bars was higher, leading to a significant difference. Talking about the risk factors for obesity after transplant. So we discussed pre-transplant obesity is the risk factor for post-transplant obesity, but other factors which are important include the dietary intake, limited physical activity, immunosuppressive medications, younger age, female gender, and African-American race. So talk about the dietary intake. We know after transplant, there are lower dietary restrictions, there is increased appetite. And we did a study at our center where on predictors of weight gain. And the best dietary predictor was total carbohydrate intake and not the total calorie consumed. So the calories from carbohydrate was best dietary predictor for weight gain. Interestingly, a higher mental composite score, which is a score for a higher for mental quality of life, so a higher perception of mental quality of life, and a feeling of well-being was associated with weight gain. There was a study from Turkey where they looked at 3-day average calorie intake, and as expected, the calorie intake was higher in first week at month 3 and 6 as compared to first week, and the 6-month weight gain was associated with average calorie intake at all these 3 points, at first week, first 3 months, as well as 6 months. Looking at the physical activity, so we know transplant specific factors contribute to the lack of exercise. And from a survey done at our center, the barriers to physical activity that were identified, one of them, well, the biggest one was the fear of injuring the new kidney, health problems related to unrelated to transplant. These were patient reported reasons, and time constraints after returning to work, which is encouraged after transplant. There was a systematic review of studies looking at physical activity recommendations, and the key points from that was that there was majority of patients had a lack of motivation for physical activity. A majority self-reported themselves as being sedentary. And interestingly, only 45% of patients reported that their providers discussed exercise with them at their visits. This was another study looking at comparing kidney transplant recipients non-diabetic with healthy men. They were matched for height, age, and lean body mass. And they compared daily energy expenditure in chambers, so the calorimetric chambers, and then subsequently in free living conditions. And they divided the group into weight gain, no weight gain, and healthy control. And as expected, the weight gain group had a higher fat mass without change in lean body mass, but they also had a higher daily, actually it's lower, sorry about that, lower daily sleeping and resting energy expenditure adjusted for lean body mass, and a lower free living physical activity. So again, in this graph, the weight, all of them had lower activity counts when they were in the chambers, but the non-weight gain group and the healthy group had a higher activity count when they went outside as compared to the weight gain group. Talking about the immunosuppression, we have a positive correlation with CNI, specifically cyclosporin more than the tacrolimus, and a negative correlation with mycophenolic acid, likely contributed by the GI side effects as previously mentioned. There's previous mice models of colon inflammation also causing weight loss. And contrary to what would have been expected, corticosteroid use in itself is not associated with higher BMI or higher total body fat, specifically because of the lower maintenance dose that is being used these days. And this was a graph from a study which compared tacrolimus versus cyclosporin. The black bar is cyclosporin, and at different points after transplant, cyclosporin was associated with more weight gain as compared to tacrolimus. I won't spend a lot of time on these dietary recommendations, but I just want to point out that in the early phase, which is 6 to 12 weeks with a functioning allograft, there is a higher protein requirement and higher calorie requirement. And it's okay to have a higher carbohydrate, higher percentage of calories from carbohydrates, but this is only in the initial phase. And then in a maintenance phase, the caloric intake has to be individualized, and the protein intake should also be reduced and individualized, and plant-based should be preferred. This was so Mediterranean and DASH diets have both promote balanced meals with emphasis on whole grains, vegetables, fruits, poultry, and fish. This was a study looking at Mediterranean diet, and a higher score was inversely associated with graft failure, kidney function decline, and graft loss, and also associated with reduced oxidative stress and inflammatory markers. So this was Mediterranean diet and this looked at a long follow-up of 5 years. And DASH diet, this was a prospective cohort of 600 transplant recipients, and a greater adherence to the DASH diet was associated with a lower decline of kidney function and a lower risk of all-cause mortality. I like to show this and talk to the patients about, and this is a good visual graphic but this is from a study just recently published in Kidney International Reports. Gives a nice visual graphic of how the patients should divide their food, their plate, and how they should source their vegetables, their proteins, their grains, and healthy fats, and including the salt and the beverage recommendations. I understand that this can be customized or individualized for patients in India, but the principle is still the same, that it should be a balanced plate and balanced diet. For exercise recommendations, whatever exercise recommendation intervention needs to be there, it has to be multi-component. It should include aerobic exercise, strength, as well as yoga. We had a survey at our center where recipients reported a desire for early interventions to increase physical activity. So the recipients themselves wanted some guidance from their providers, which would include a written instruction and then also advice for gradual increase over 6 months. There was a systematic review of exercise training and 3-month program of aerobic or resistance training improved cardiorespiratory fitness. And the recommendation was to achieve what WHO recommends, but customized to make it sustainable. So if WHO recommends 150 minutes of moderate physical activity, for someone who's 65 with joint issues, that might not be completely sustainable. So could there be other ways that you could achieve? If it's not walking, could there be biking? Could there be other modalities where you can still achieve a moderate exercise or moderate aerobic activity? And it could be supervised or it could be home-based. Quickly about the pharmacological measures, the weight loss drugs that are available have not been studied in kidney transplant recipients. The ones which are available, orlistat, the combination phentermine, topiramate, or herbal remedies mentioned in the previous talk, they all interact with CNIs. But there are new indications for GLP-1 agonists as weight loss drugs, the liraglutide and the semaglutide, and potentially could be used for kidney transplant patients. They have been approved or going to be approved for weight loss in diabetics as well as non-diabetics. Although there's a concern for delayed gastric emptying, and which can affect CNI levels. But there was a case series from 2013 which looked at only 5 patients with tacrolimus liraglutide, and although the AUC was lower, but the trough concentrations were similar. So we have started using the liraglutide in some patients, although insurance is a difficult obstacle, but we are hoping to use more of these drugs in patients who are not doing that well with lifestyle modification. Just a quick slide about bariatric surgery. There was a study comparing Roux-en-Y gastric bypass after kidney transplant. And although at 6 months, both had a drop in the BMI, there was no difference in diabetes or graft outcomes. And the pharmacokinetics of tacrolimus was affected, but not cyclosporin. But there was another study of sleeve gastrectomy before and after transplant. And although there was no difference in BMI at 5 years, the bariatric surgery group had a lower risk of allograft failure and mortality in post-transplant. And sleeve gastrectomy did not affect the pharmacokinetics of tacrolimus. We do not have long-term data on bariatric surgery after kidney transplant. So in summary, the benefit of obesity on dialysis doesn't translate into benefit after kidney transplant. Sarcopenic obesity after transplant is more common than healthy weight gain. Obesity should be assessed by BMI, waist circumference, and if available, other anthropometric parameters. Dietary counseling, there's plant-based, Mediterranean, DASH, and exercise counseling should be a part of all post-transplant visits. And potential for use of weight loss drugs and bariatric surgery is there, but only in addition to a structured multimodal regimen of lifestyle modification. Thank you, and I thank the organizers for inviting me for the talk.